Now I move on to another complex subject, and that is solving the enigma of DRS, the Duane's retraction syndrome. So Duane's retraction syndrome, as you see, is one of the most common CCDD, the congenital cranial degeneration disorder, which is because of the sixth nerve aplasia to start with, and it was initially described by Hewitt and Stilling and then Duane's. It is 1 to 4% of strabismus patients. There is a surprising female preponderance of about 60%, and unilateral cases more of left predominance. The interesting part I learned from Parsa's article why this is happening. That's something which I would like to always say. So in this, what is happening is there is an innervational problem. Primary disinnervation is lateral rectus not getting innervation during abduction. Secondary disinnervation is that the lateral rectus is getting innervation during adduction or at both times. Okay. So ESO-DRS are cases in which the lateral rectus doesn't fire during abduction but starts having innervation during adduction, and classically you see them as ESO-DRS in primary position with marked upshoot, downshoot, retraction and narrowing in adduction. On the other hand, the exo-DRS cases are exo in primary position but a similar picture in adduction, and they may have sometimes normal abduction, sometimes they also have limited abduction. So each case has to be seen differently. So these studies of the, if you see the MRIs, you will see them that there is a missing nerve, sixth nerve or the pons. And as we can explain the paradoxic innervation, we need to tackle it in the same manner. Also remember, there are associated ocular problems which are there. The one common thing which we usually used to miss, but I think thanks to Marilyn Miller, I always ask the question about crocodile tears. And this is something you'll find in many cases when the mother will say, oh yes, whenever he eats biscuits or anything, he tears, his eyes are tearing. So this is the abnormal gastro-lacrimal reflex which happens. A Marcus gun jaw winking is another common thing which you may come across. So Duane's retraction syndrome systemic associations are also there. So ask about these. And the syndromes which are associated like golden Haar, Klippel-Feil, Wilder-Wank, Holt-Oram, Okihiro, or the IVIC syndromes. So these are associated things which you will have to keep in mind whenever you have the case of DRS. Ask about these, like here the neck is short neck and there is a Marcus jaw winking, deafness is there in many of these. In Holt-Oram again, cardiac anomalies may be there along with the morning glory. The embryogenesis is interesting. Around 4 to 8 weeks of embryogenesis. Again, thanks to Marilyn Miller, we learned about this. Thalidomide and misoprostol is one of the culprits in some of the cases. It's the higher estrogen level and inflammation which causes venous thromboembolic events. I think an interesting article by Parsa and Robert in JAMA Ophthalmology 2013 is there, which I like because it suggests that if we can control thrombogenic influences during the first trimester in these pregnant ladies, we may be able to probably prevent having Duane's retraction syndrome in future. So genetics counseling, yes, there may be some cases, about 20%, which may have genetic disorders associated. Gene review may be done. How do we manage in this surgically? What I say is that follow first of all whether it's an ESO, EXO or ortho. Second, look for the co-contraction. By rule, co-contraction is always there. See whether it is significant, mild or very severe. How much is the normal LR activity? Now this is particularly seen in exo-DRS cases. It will change our management. And finally, force reduction test both for MR and LR. So these are the 4 points which I have sort of taken the gist out of a wonderful article in Rosenbaum's book by the great Jampolsky. And in that chapter will take many months to read and understand. But if you can summarize, I think this is 4 points which I got. These have to be kept in mind. So if you have a case in which there is a ESO-DRS in the primary position, the FDT MR is positive and minimal co-contraction is there, you need to do an LMR recession for just the tightness of the MR. Minimal MR recession is what we need to do, and that does the job. If you do more MR recession, you will land up into a iatrogenic synergistic divergence. Because there is a co-contraction, you have weakened the medial rectus force, the lateral rectus is now uncontrolled and it causes an exo whenever the person is looking on adduction. So this is something you have to be aware of. Again, that figure is from Jampolsky's chapter. So what we do in such cases, whenever there is a moderate to severe co-contraction, always balance the lateral rectus with a split LR and recession. A Y split LR with recession, a split should be at least 22 millimeters from between the two ends. So in ISO DRS, what you do is this, that you will do a MR recession along with the split LR recession with that. I think there are some articles, especially I think from Canadian group, that you may do a little bit of resection by, generally we say don't do LR resections in DRS cases. But I think there are some reports, but I think you have to read between the lines. What he has said is never do more than 3 to 4 millimeters of resection. Very small amounts of LR resection he has talked about for ISO DRS. So in ISO DRS, when there is FDT is not there for MR, you may do only the SRT, and that may be just enough for improving the abduction as well as correcting the ISO. So this is the planning algorithm for ISO DRS. For exo DRS, our strategies will depend on how much is the exotropia, how much is the co-contraction, how much is the LR activity, whether it is normal or it is missing. Now, if there is some LR activity, you don't want to sacrifice the lateral rectus. So you do an LR recession with Y split, and many a times 12, 14 or up to 20, 30 prisms of exo will be just corrected by single muscle surgery, LR recession with the Y split. LR recession will depend upon the exo in the primary position and the retraction, and the split is going to take care of the upshoots and downshoots. Remember, it's a recession which is taking care of retraction, not the split. The split is only taking care of upshoots and downshoots. So this is a procedure of LR recession with Y split in exo DRS cases. Little is no good for exo DRS. I think this is again one point which Japolsky talks about, that he says that you may have to do for each prism 1 millimeter of LR recession. So you have to be very careful in how much recession you do, and sometimes we have to do a periosteal fixation of LR along with the partial VRT to improve the abduction. I don't want to go into this detail of the video. You can see on the net, this is available. Adjustable partial VRT, or nowadays the Nishida procedure is very handy that we do. So you can, now this guy we did a partial VRT, and you see the abduction is improved along with the exo DRS getting corrected in the right eye. But here we have done a modified Nishida to improve the abduction, and this is something which now has been promoted by some people as that double K Kushner and procedure. So plus modified Nishidas and LR recession with Y split can be done. So the exo DRS planning algorithm is this, that you will depend upon the LR activity, how much and what to do. Ortho DRS are more difficult to handle because they have a challenge to be maintained, that ortho is to be maintained in primary position, and still you want to correct the problem in the adduction. You have to do an MR recession on an adjustable suture and LR recession with Y split. So this is what is the take home in the DRS cases. ISO DRS, MR recession alone, or MR recession with LR recession with Y split, depending upon the severity of co-contraction. Exo DRS cases, large LR recession along with a Y split, or if there is a no LR activity, then you can do a periosteal fixation for very severe exo DRS cases. And abduction you can improve by partial VRT. Ortho DRS cases, do an adjustable MR and LR recession with Y split. And to improve abduction, which can only be done if the LR paradoxic activity has been already taken into account. The risk of ASI should be kept in mind. Don't want to handle the vertical recti in the presence of both MR and LR.